Hello there. Welcome to our program. I'm Dr. Lewis Hassel, a professor of pathology at the University of Oklahoma. And our program is the consequence of a joint venture between Path Presenter and the Digital Pathology Association. We utilize those materials liberally in our program. Now, while usually we talk about individual cases, today we're going to take a slightly different approach and talk more about a particular topic, an organ, and utilize the resources of the Path Presenter and Digital Pathology Association site to help explain these concepts. We're going to talk about parathyroid disease and specifically prepare you with just about everything you might need to successfully pass any questions the boards could throw at you on parathyroid disorders. So let's just begin and review kind of what the normal anatomy of the parathyroid is. Here we see a very small glandular tissue here amidst skeletal muscle, fat, some vessels, and maybe even an occasional little lymph node. So as we look at the surrounding tissues, you can see that this is really quite a small organ. And importantly, it's sprinkled throughout with lots of clear space that corresponds to adipocytes. The normal parathyroid contains quite an abundant amount of fatty tissue, and so much so that it may occasionally be almost inconspicuous to find the parathyroid tissue. Sometimes surgeons will sample a little lobule of fat, thinking that that is the parathyroid. Additionally, the other thing we can see here is that there are several different cell types that make up the normal parathyroid. We have the dominant cell type here, which you can see has nice rounded nuclei and pale bluish purple cytoplasm. There may also be areas where there are clear cells. As you can see here, there are a couple in this field over here as well. And then we may get more oncocytic type cells with pinker cytoplasm, somewhat more abundant. And all three cell types can be present equally within the parathyroid in varying proportions, as well as in some of the neoplastic and hyperplastic proliferations that we can encounter in the parathyroid. Now, in addition to neoplastic disease and hyperplastic disease, there's one important disorder which can be encountered, which we present here, which, as you can see, is a cystic space. And in the wall of this cyst is, yes, you see fairly normal appearing parathyroid tissue, a little bit of admixed fat associated with it here, some clear cells. But then we have this fibrous walled cyst, which also is lined by the characteristic cellular components of the parathyroid. Now, these might be indistinguishable from any other cuboidal epithelium, but were you to do immunohistochemical stains, you would discover that these will stain with markers that similarly mark the parathyroid. Now, the importance of this is that on rare occasions, this cystic lesion may become clinically evident and may be sampled either by a fine needle aspiration or, as you see in this case, surgically. That's when it becomes important to be aware of this entity because in addition to finding the lesions that we've identified here, the chemistry on this fluid will disclose an elevated PTH content and not the usual findings that you might associate with a thyroid cyst of colloid and so forth. The contents will be watery clear usually, and if you're alert to that, you can rarely make the diagnosis of a parathyroid cyst on a needle aspiration biopsy. The other fine feature to be aware of, as I mentioned, is that in some situations, the dominant pattern can appear very oncocytic, and as you see here, could mimic a thyroid oncocytic lesion, such as you might see in Hashimoto's disease or in oncocytic adenomas. But again, these cells would not stain with usual thyroid markers, thyroglobulin, TTF1, et cetera, but could still then, of course, be related to a disease in the area related to a parathyroid neoplasm. Well, let's talk about some of the things that might clinically bring a patient to our attention with parathyroid disease and lead to investigation and the kind of surgical intervention that usually we're dealing with parathyroidectomies. In fact, in the Western countries, most parathyroid disease is detected at an asymptomatic stage due to hypercalcemia. Now, that may be associated with some rather nonspecific symptoms that very astute clinicians might be able to attribute, tie together in the setting of occult parathyroid disease. And these would include things like, loss of appetite, fatigue, weakness, maybe a little bit of psychological, mild depression, et cetera, and some degree perhaps of even cognitive decline or neuromuscular dysfunction. But these can be rather subtle and maybe even transitory at times, making this diagnosis on the basis of symptoms somewhat difficult. But in the setting of hypercalcemia, then further evaluation might lead to identification of elevated PTH levels. When parathyroid disease becomes symptomatic, however, it often goes under the sort of mnemonic of bones, stones, abdominal moans, and groans. So if you're a poetic rhymer like I am at times, those various owns might bring to mind the sort of symptoms that might be expected. So there can be osteitis, fibrosis cystica. There can be, nephrolithiasis develop. You can have patients develop anorexia, nausea, constipation, pancreatitis even, polyuria, various other abdominal complaints. And then the psychological sorts of things that we've talked about: confusion, fatigue, decreased concentration, stupor, cognitive decline, et cetera. Now, in addition, the hypercalcemia can also lead to bradycardia, even hypertension, or other EKG manifestations of a biochemical disturbance. As we think about then the further investigation, this can lead to a pathology that is associated with excess PTH secretion. And usually that will be documented from the chemical side of things, because when this is purely present, these are the kinds of things that we will see, even to it including anemia as well. But hypophosphatemia, increased calcitriol, renal tubular acidosis, hypomagnesemia, et cetera, these sorts of changes can also be present in pure association with excess PTH. So then, once you've identified that you've got hypercalcemia, excess PTH, what are you going to do about it? Well, the various pathologies really come down to about 4 different things. Most typically, this is hyperplasia. Well, excuse me, not most typically. Most typically, this is an adenoma, a small benign neoplasm that is producing excess PTH. And so that may be localized as a single gland that's enlarged, or maybe on occasion a dual gland that is enlarged. And that will be accountable for the excess of PTH. Now, the situation of hyperplasia can be sporadic and can be spontaneous, or possibly related to a number of syndromes, MEN1 or 2A. There is a familial type of hyperplasia, but actually quite commonly, this is a secondary phenomenon that is secondary to kidney disease or low vitamin D and so forth. And so that scenario where you have secondary disease can be problematic because you may not be able to control it appropriately with kidney disease and so forth. And then the least common possibility is carcinoma, which accounts really for less than 1% of parathyroid surgeries. So how are we going to sort out these various possibilities? Because essentially all of these have in common an excess of PTH. Now, the history may help, the family history may help, testing for other possibilities may help, but basically in order to control the hypercalcemia and the excess PTH, you're going to have to do surgery. So that then leads to sampling. And ideally, because the nature of the surgery can vary based on what you find, there are a number of important considerations intraoperatively. It comes to frozen section, essentially. Size and weight of the removed gland are very important. And identifying initially that adenoma can be very, very helpful. So identifying that it's a hypercellular parathyroid, that you have no parenchymal fat, et cetera, may help you to say this is most likely an adenoma. And that's particularly reinforced if you're able to do intraoperative PTH levels, which will show a dramatic decline with removal of an adenoma versus a nominal or minimal decline in the setting of removal of a single hyperplastic gland. So those two decay curves, if you will, in the PTH level can be virtually diagnostic in and of themselves, perhaps even without frozen section, sort of a chemical frozen section, if you will. Well, let's talk about the morphology. So with a parathyroid adenoma, which is going to be the bulk of our cases, you're going to have a decreased or absent amount of parenchymal fat. Now, these cases also show a decreased amount of cellular fat if you're in the position to do any sort of lipid-based staining or any water-based staining that will reveal to you the amount of cellular fat. So at times we've used a toluidine blue stain, for example, as a rapid stain of a frozen section slide without the dehydration and lipidization of xylene and so forth to evaluate for those things. Parathyroid adenomas usually have a thin capsule, and they may, if you section them appropriately, have an adjacent area of more normal appearing parathyroid gland. And that can be helpful if it's present. If it's absent, well, that doesn't exclude the possibility, certainly. And as we've mentioned, the cellular composition can be oxophilic cells, water clear cells, the more typical chief cells, and occasionally you can get atypical cells, some atypia, even mitoses and so forth, that might put you in towards a more borderline category in some settings. We've mentioned the rapid decay of the PTH level. If you need to do immunohistochemistry, which in most cases you don't, you're looking at negative stains for thyroid markers and positive stains for any of these markers that can be indicative of thyroid epithelium, including the various low and high molecular weight cytokeratins, GATA3, and PTH itself. So let's take a look at one of these. Here's a small gland, which, as we can see, has a diminished amount of intracellular or intraglandular fat. We see just maybe a couple of remaining lipid droplets here, or clear spaces. We see a cellular tissue, a little pseudo follicle-like structure here. And of course, this sometimes can create confusion with a cellular parathyroid, or excuse me, thyroid lesion. And aside from that, the morphology is pretty typical. Very nice round cells, a little bit of clear cytoplasm, a little bit of amphiphilic cytoplasm, highly vascularized, and no other specific findings. So this would be reported for this frozen section as a hypercellular parathyroid tissue. And then you have to then defer to what the chemical findings or additional glands that may be removed for comparison. Here's another example. Again, we see this one as an enlarged gland, a bit of lobularity, a thin capsule around the periphery, and not much in the way of fatty tissue. We see rather we've got a nicely vascularized structure, a little bit of follicle type pattern with some of these cells, and mostly these oxyphilic cells. And here, a little separate nodule with a degree of atypia you see here, little nuclear pleomorphism, and the more water clear pattern cells. Now, this, of course, doesn't make it necessarily an atypical adenoma or even or by any means a carcinoma without finding other features. but just to illustrate the type of variability that you may see in some of these nodules. Obviously, the weight on this gland would be significantly higher than that in a normal parathyroid gland, probably 4 or 5, maybe even 10 times higher than the normal weight. So how does that contrast with hyperplasia? Well, in hyperplasia, you're getting multiple glands that are enlarged. The weight usually is not going to be quite as great as with most adenomas, but depending on the stage at which this is discovered, they can be close. Again, you'll have loss of parenchymal fat, but there should be generally no residual normal parathyroid tissue, and certainly no capsule seen. These usually will have chief cells, but there are also water clear variants. Now, the history may help in the situation, if someone says this patient has renal failure or something, or if you're aware that they have other endocrine abnormalities from prior surgical procedures or something of that sort, that may help you. But generally, the surgeons will want to remove 3 to 3.5 glands in order to verify this diagnosis. And each one should be weighed and included in the total weight that you're evaluating, and frozen section performed to verify the hypercellularity that you've got. So what does this look like under the microscope? Well, here's another example. Here again, we see some nodularity. We don't see any peripheral rim of normal gland here. We do see a little bit of residual parenchymal fat here, but certainly markedly reduced when you compare to what we looked at initially. Again, we see some variability between the architecture, some nodularity, some more eosinophilic cells, some clear cells, some oxyphilic or chief cells here as well. And you see maybe a little bit of fibrous banding here as well. Now, that doesn't make this malignant by any means. Here's, again, a nice follicle or pseudofollicle type of space. Now, we said that you shouldn't see any normal residual gland, and you might say, well, what about this? Would this qualify? Well, it might. And so sometimes that criterion can be a little bit confusing because you can't really tell if this is decreased fat or just like some areas of this nodule where you have a little bit of tiny residual fat in that gland as well, which we saw over here. For example, in this area. So that criterion can be a little bit difficult at times to handle. But with that said, let's take a look at another example. Oh, excuse me. Let's go on to parathyroid carcinoma. So this is, as we mentioned, much less commonly encountered, less than 1%. And to make the diagnosis with histology, or other findings, you really need one of the following to be definitively present. Blood vessel invasion, lymphatic invasion, perineural invasion, invasion of adjacent structures, thyroid, fat, muscle, etc., or metastasis. So you have to define invasion. This is not a diagnosis you're going to make on the basis of strict architecture within the lesion. However, there are some things that can raise your suspicion and make you look harder. So, for example, if you find definite capsular invasion, that should be something you look at very, very carefully and perhaps do multiple sections, multiple levels to see if you can identify vascular invasion. A gland that's very difficult to remove or has a lot of dense fibrous bands, particularly with sort of stellate radiation. On the chemical side of things, a PTH level that is really multiple times greater than the normal range should also raise consideration of this possibility. Likewise, a so-called malignant hypercalcemia type of picture could be considered as well. Necrosis, mitoses greater than 5 per 10 millimeters squared. These are, again, softer findings, but certainly should raise consideration and not uniformly present in malignant cases, but could be a marker to cause you to look further. So here's an example. Now, you might look at this initially and say, gee, this looks a lot like that adenomatous gland. It's very blue. There's no distinguishing fat here. We've got a hypercellular gland and not a lot of pleomorphism here. There's a little variation in cell size and shape, but we don't see any frank dysplasia or anything of that sort. And in fact, this is a case where two findings can be helpful. One is here it looks like you've got a capsular invasion that begins to come through this capsular band. And so you've got this sort of mushroom pattern of invasion. Now you might say, well, is this vessel invasion? You've got a lot of blood here. But I don't think this is definitely the invasive component. Now here, you've got a little vessel, and it may be that this is pushing towards that vessel, but I don't think in this particular field or in this particular area, you can define blood vessel invasion particularly well. Here again, you start to see a little suggestion that you're pushing towards these vessels, and that raises concern and consideration. Let's go back here, though. We did have an area where we were helped by the initial evaluators to identify that feature, which I think you can see here. In this situation, I think we can identify that we do have blood, we have an endothelial lining, and here we have the protrusion of this nest of follicular type parathyroid cells into the lumen of this vessel. So this very nicely, I think, can be convincing for either lymphatic or vascular invasion. Whether this is a blood vessel or lymphatic is hard to tell for sure at this point. So with that and the capsular invasion and the other features that we've talked about, I think you could, in this case, make a diagnosis of parathyroid carcinoma. Now, that doesn't mean that necessarily it's going to be advanced stage and that surgery won't cure the patient in this situation. It's certainly much more likely because this seems still fairly encapsulated, and barring distant metastasis pre-existing at this time, you would make that diagnosis. Now, here's a little finding here. You might say, well, is this capsular invasion? And I think in the thyroid, you might certainly worry that that was the case or do additional levels. But as we've mentioned, this is only just one of those things that raises concern. It does not establish the diagnosis of malignancy in parathyroid carcinoma. Here's another example. This is a gland where we can see maybe a little bit of residual, more normal appearing parathyroid out here. And then this hypercellular parathyroid gland here. Notice here we are starting to get some nice dense fibrous bands, as you can see here, cutting off different islands of this lesion. And here again, a little bit maybe slightly normal parathyroid. But then we see here evidence of certainly capsular invasion. And if you'll believe me that these cells marked as endothelial cells in this particular space right here, you might accept that as being vascular space invasion. Now, sometimes we do need to do endothelial markers to be certain. We use either CD31 or CD34 as those markers. Here again, though, we see an area of capsular penetration, which goes nicely through this capsule here, extending into the periphery. So these are markers. Here's another area here. And the more of these kinds of findings that you find, the more likely it is that you're going to be dealing with a parathyroid carcinoma. And likewise, the more likely it is that this was a lesion that was somewhat difficult to remove. We'll take an additional example here. This parathyroid gland here, we can see, again, this very dense fibrous band of tissue. We see a little bit of inflammation here, but no definite vascular invasion. But here it was evident that the lesion was extending into the thyroid gland. Now, of course, many times the parathyroids may be actually intraparenchymal within the parathyroid, and so identifying that could be difficult. Again, here's another area where we have certainly capsular invasion and probably capsular penetration. That could be a clue to then look for additional findings. Here's some hemosiderin outside here associated with some lymphoid inflammation. Actually, this may be parathyroid tissue here that's gotten some hemorrhage. So in this case, a combination of penetration into adjacent thyroid, capsular penetration in one or more areas, and potentially, if you had endothelial markers, some vascular invasion on this case. So one more example, let me show you. Oh, I guess that's it. So just to summarize then, adenoma and hyperplasia do require very careful histologic and chemical correlation. Parathyroid carcinoma is decidedly rare, relatively few histologic clues, but those would be vascular invasion, lymphatic invasion, adjacent organ invasion, and metastasis, of course. So thank you so much for joining me for this. I will include the link to these slides and to this presentation in the description. And I hope this is helpful and that you will score 100% on all of those board questions on the parathyroid. So until next time, thanks so much for joining me.